Hello, everybody. Dr. Nikhil Verma here with another edition of Things I Didn't Learn in Med School. Today, I want to talk about a conversation that I had in one of our group chats. This group chat that I have is of fellows and former fellows that graduated from the same fellowship program that I did in Birmingham, Alabama. And in this group, we discuss a lot about best practices, recommendation on difficult cases, learning points. It's really an extension of our fellowship at this point where we can challenge each other's ideas. We can have a free and open space to discuss, hey, we have this going on. How would you handle it? Billing questions, changes in laws across the US. And really, it just has developed into friendships where we can have other conversations within the group chat as well. This chat has actually been so great that we've even extended it out to trying to do a fellows retreat once every other year so we can be in person. And this is actually, we're setting it up to have continuing medical education at these conferences as well. And it's really great because we have someone else to lean on in these times. Now, I'm sure other groups have things like this, but what I find beneficial is a conversation that came up this week. We were discussing how patients will quite frequently come to our practices and they will be completely shocked that the physician, ourselves, want to look over the MRI images with the patient. Quite frequently, they'll go to other physicians and the physician just reads the report. Their pain doctor will just read the report and then jump to a conclusion of what procedures they want to do. We were trained and drilled into our heads that we should never touch a patient with a needle around the spine unless we know exactly what is there. And that's why we look at the MRIs. It also helps with our planning. What angle of attack is going to be the best, most efficient? Is there something that's there that's going to cause us problems? Bone spurs or some other obstructive masses? Or is there something going on that the radiologist missed? That happens infrequently, but it can happen. The other thing that we look at when we're looking at these MRI is the report will say one thing, but the patient's symptoms don't match the report at all. So we have to go back and see what is going on. And that's the second part of what we learned in the fellowship is that really thorough physical exam to see where the pain point is and what is going on. Because all back pain is not the same. We can have the facet joints causing pain. We can have the disc causing pain. We can have the vertebral bodies causing pain. We can have sprain and strains in the low back muscles and the ligaments. Is it a part of the disc? Is it an annular tear that's causing pain? So it takes a real nuanced training and a really adequate view of these images to understand what's going on for all these things as I mentioned above. And it really shocks me because some of these places that these patients have gone to, they are university centers. They are highly sought after orthopedic centers in the areas that we're all practicing. Now, we practice all across the United States as fellowship group. And it's just really fascinating because this conversation came up in my practice this week, but it also came up for someone else and in the fellowship group, and we all started discussing it. This is also the big difference between going to some training programs who just need to churn out fellows. They don't necessarily care all about that education. Of course, they want to have fellows out there that are safe and practicing physicians that know what they're doing. But they also want to make sure that they're getting these fellows to do a lot of the work, the leg work, because that's the only way in the RVU system to make profits for the physician. And I don't want to get too much into that right now. It's kind of a topic for another day. It's just how the system is essentially set up, that a physician gets paid based on the volume that they do. And now volume doesn't necessarily mean just procedures. You can have volume for office visits and consults and these kind of things. But better or worse, for better or worse, that's essentially how a physician gets paid and base their value from that. So how do you increase that value? By seeing more and doing more. How do you see more and do more? Is you have fellows work with you. Um, and that's just how the system is, and that's how every system is you find a way to have people working under you so you can do what you do best. But it can be, for some programs, just a churn and burn. They just get these fellows in, and you get this university degree, ACGME accredited paying fellowship slapped on the wall, and you like, okay, now this is my ticket into a job anywhere. But the practical knowledge and the practical reality of actually practicing medicine outside of the fancy degrees, as I call them, is where's the nuance? Where is these physical exam that should be a very vital portion? Where is the imaging review with the patient so they understand and also you understand what you're doing and what procedure you're going to do? I'm not going to sit here and try to act like we have a perfect fellowship and everything we did was 100% right and it's the only way to do it. I'm not doing that. I'm just saying that this is one thing that I think separates a good physician from a mediocre physician. They might have the best procedural set in the world, but are they doing those extra things? Are they approaching it with hey, let me take a look at this myself to confirm or review what is shown in front of me on this MRI report? But I also think that this is why it's important to have lots and lots of different types of training out there. And this is why it's important to have continuing education out there. What we were trained on was from physical medicine rehabilitation trained physicians who went to interventional spine fellowships, and they were teaching us. But what we're not getting enough of is having a licensed MSK radiologist sit with us and show us even more nuanced things. And that's one great thing about a lot of the societies that we have. They do partner with a lot of these interventional radiologists and MSK radiologists, so you can sit there and review the images at a high level, and then you get more confident reading these images yourself, therefore getting better patient care. And I think that's what the whole overarching topic I want to talk about today and have talked about today. And I think that's pretty much like what I want to talk about. I don't want to go too much more into anything else today, but I thought it was an interesting conversation. I thought it was a great video to make and make it really short and sweet for everyone today. So I hope you found this useful. If you have any more comments, questions, please drop them below. Send me some messages. Happy to talk more. Talk to you soon.